Good evening, everyone. My name is Christina Argeullo, and I am a current MSc student in medical anthropology. And tonight I'll be talking about, seeing risk and assigning responsibility, spatializing visibility and accountability in healthcare. So my project in particular looks at how healthcare systems frame responsibility for risk, and particularly how these framings shape what becomes visible and what remains less visible within medical practice. And I want to say that my mom, who is a registered nurse, inspired this project as a registered nurse who works frontline A&E. So my leading research question is as follows. So basically my research asks how responsibility for risk is framed again within healthcare systems, and what these framings reveal about how then this accountability is distributed. So rather than measuring outcomes, I'm interested in how risk and responsibility are constructed through language, representation, and these different institutional narratives. So the core argument of my dissertation is that healthcare doesn't just manage risk. It actively shapes how responsibility is understood. So in particular, responsibility is often made to appear individual, for example, through ideas like professional judgment or clinical error, while the structural conditions shaping care, so this can be staffing pressures or institutional constraints, are then they become less visible. And across both historical and contemporary contexts, healthcare systems consistently render intervention and individual action visible as sites of responsibility, while structural conditions remain less visible as these objects of accountability. So, by linking spatial organization to then institutional discourses, the project advances a medical anthropological account of healthcare, in which responsibility is understood as a product of representation rather than this neutral response to risk. What I'm trying to show is that all this is not accidental. It's produced through how medicine represents itself. So I would argue my working thesis as of right now is that healthcare documents often acknowledge system pressures, but responsibility for problems against them mainly is placed on individuals, whether that be the patient or the practitioner, which can then wider than these structural issues less visible. My project is, again, sort of grounded in medical anthropology and draws on then these three main areas of theory. First, work by scholars by Byron Good and Locke and Nguyen. They argue that medicine should be understood as a cultural system. So that means that medicine doesn't just treat illness. It produces particular meanings about bodies, risk, and intervention. And then I draw on work around visibility and knowledge, particularly around Foucault's idea of the medical gaze, and Anne-Marie Moll's work on how realities are enacted in practice. These approaches help me think about what is made visible and what shapes what can be known. And lastly, I draw a literature on risk, responsibility, and inequality. Mary Douglas shows how risk and responsibility is socially organized, while Didier Fashin and Paul Farmer highlight how institutions assign value and distribute responsibility unevenly. Synthesizing and putting these all together, these perspectives allow me to then analyze how healthcare systems construct responsibility, not just through what they say, but through what they make visible and what they obscure simultaneously. So sort of methodologically, my project is sort of designed in two parts. The first part, which I've completed thus far, it's a spatial and visual analysis of the Old Operating Theatre Museum in London, which is the oldest operating museum in Europe in general. I treat the museum as a representational system, analyzing how space, object, and text work together to construct particular understandings of medicine. So this includes looking at spatial organization, so how bodies and observers are positioned, visual arrangement, and how instruments are displayed, and textual framing through labels and institutional narratives. The second part, which I am currently working on, it is a discourse analysis of healthcare policy and institutional texts. So sort of in this part of it, I'm examining how risk is framed, how responsibility is attributed, and what kinds of factors are included or excluded in those framings. I think what's important is that these two methods are very interconnected. The spatial analysis helps me identify patterns of visibility, which I then trace to in contemporary policy discourse. So why spatial analysis? This is a key approach to my research, and is taking the space seriously as an analytical object. So rather than treating the museum as simply historical content, I analyze it as a spatial system, one that organizes how knowledge is produced. I treat the museum, in this case, again, not as a historical backdrop, but as an analytical apparatus for examining how medical knowledge has been structured through regimes of visibility. Because space is not neutral. How it's taken up is not neutral. It structures who is able to see, what is made visible, and how that visibility is in a range. So instead of only asking what medicine says, I'm asking how it is physically and visually organized. The diagram here illustrates that logic in simplified form. It shows that the patient's body is positioned in relation to the observers and how vision is structured spatially. What this allows me to do is analyze not just representation, but the conditions under which medical knowledge then becomes possible. So this slide applies the framework to the actual space. On the left is the old operating theater itself, and on the right is a diagram that I've used to abstract the structure. What we see here is the patient's body, again placed in the center, while participants and observers are arranged in elevated tiers around it. This produces a clear hierarchy of vision, where these higher positions look down onto the body. So then, as a result, knowledge is produced through observation rather than through experience. And I think importantly, this creates distance. The viewer, which includes us, is able to see clearly, but remains separated from the patient experience. And this distance allows intervention to appear controlled and rational, while the uncertainty in a body experience of care remains less visible. So what the space shows is how medical knowledge is not just produced through practice, but through the spatial organization of then this visibility itself, and the conditions of care, so that includes labor, inequality, and uncertainty, remain pretty peripheral. And then this genealogical analysis is extended through, as I said, a qualitative examination of contemporary healthcare policy and institutional texts. So this includes NHS safety and governance framework. Specifically, I'm working with documents such as NHS patient safety strategy, the serious incident framework, and its updated PSIRF model, as well as guidance around the duty of candor and clinical governance. These documents are useful because they formally outline how healthcare systems understand and manage risk, and how responsibility is assigned then in these cases of error. Analytically, I'll be looking at how risk is described, whether it's framed as individual, systemic, or both, how responsibility is attributed, and then what kinds of factors are included or excluded in these accounts. The aim is to see where the patterns I identified in the museum, particularly the asymmetry between visible intervention and less visible conditions, also appear in contemporary institutional discourses. In terms of contribution, this allows me to connect historical forms of representation to current healthcare systems, showing how similar dynamics of visibility and accountability may persist. I also acknowledge there are some limitations to this approach because the project focuses again on this institutional discourse. It doesn't include, say, interviews with healthcare staff or patients, so it doesn't directly capture the lived experience. However, I would say that the strength of this approach is that it allows me to analyze how responsibility is formally constructed at the level of institutions, which is, I would say, very central to my research question. Sort of building on that, this final stage allows me to bring together the spatial analysis and policy analysis into a single argument. In the museum, I show that intervention is consistently foregrounded. The operating theater centers the patient's body, while observers are arranged in these elevated tiers, as I've said before. But then at the same time, the conditions shaping care are not made visible in the same way. So now what I'm doing through the policy analysis is examining whether a similar pattern appears in how healthcare systems formally describe, train, and manage risk. Specifically, whether responsibility is articulated through individual actions, such as clinical decision-making or professional conduct, while the structural conditions of care are less explicitly accounted for. So taken all together, this suggests an asymmetry in how accountability is organized. Responsibility is made visible at the level of individuals, while the systems they operate within are less visible as sites of responsibility. So overall, my dissertation shows that healthcare systems don't just manage risk, they shape how responsibility is represented and distributed through what is made visible and less visible. And oh, sorry about that. That is my entire presentation. Thank you.